Hello everyone, this is Dr. Anmol Mishra from Radiance. In our previous post, we asked you to answer this question for us. And the question was, if we look here, we can see that this is the MR angiography of the circle of Willis. And we asked you to name two anomalies, or rather two variant anatomies that are present here. So variant anatomical conditions that are present here, we are going to discuss about that. So for that, we will have to have an idea about what these structures are first. So if we look here, this structure here, this is the ICA. So this is the right ICA. This is the left ICA. And these are the terminal branches. So this one is the left ACA. And this is the left MCA. Similarly, here we can see the right MCA, but if we want to find out where the A1 segment of ACA is, we see that on the right side it is absent. So A1 on the right side is absent. Right, so if we look here carefully, how should it have been? So this here is the right A2 segment and this is the left A2 segment. So this is pretty clear that the right A1 segment is absent or aplastic, or it could also be hypoplastic, so that it is not clearly visible here. But whatever it is either hypoplastic or aplastic. Definitely the A1 segment is not normal here on the right side. So that is first variant anatomy here. So that is an absent or a hypoplastic A1 segment on the right side. If we look at the other variant anatomy that is present here, so that is something related to the posterior circulation as well. So these are the two. So these are the two vertebral arteries. This is the right vertebral artery. This is the left vertebral artery, and here this is the basilar artery. So if we look here, these two small branches, these thin branches here, these are the superior cerebellar arteries. But if I trace this basilar artery, then this one here, this branch, this is the left PCA, that is the terminal branch of the basilar artery. However, if we look carefully, we can notice that there is no such branch on the right side, at least in its proximal part. So the P1 segment of PCA here is either absent or is really very hypoplastic, such that it's not visualized on MR angio. Another thing that we need to know here is that since the PCA on the right side is absent, at least in its proximal part, that is why it has to get some supply from somewhere so that it can supply the normal posterior circulation on the right cerebral hemisphere. And for that, it gets a little bit more supply from the internal carotid artery. Why am I saying that? If we look here carefully, just look at the normal PCOM or the posterior communicating artery here. It's so thin and small, this one here. And this large one is, large artery is the PCA. So this is the PCOM on the left side and this is the left PCA. However, if we have a look at the right side, I can see that I cannot clearly visualize the P1 segment on the right side. That is not visualized. And as a compensatory mechanism, there is a fetal or a large PCOM on the other side, such that the distal PCA on the right side gets a significant amount of supply. So this is basically kind of a double-edged sword for the patient, because just imagine if there is a blockage in or an obstruction for any cause in the ICA, then not only will it cause infarct in the MC and the ACA territory, but it will also cause an infarct in the PCA territory. And that is because this PCA is predominantly dependent on this large PCOM for its supply, and which is eventually coming from this internal carotid artery, which will be blocked in this scenario. So there is another, however, advantage that happens here, and that is, for example, because of any reason, if there is blockage in this basal artery, or if there is blockage in the PCA in the proximal part, provided that it is present here. Anyway, for the convenience sake, we will read this case as a blockage in the basilar artery. So this will cause an infarct in the PCA territory on this side, but on this side it won't be able to do that, and this region will get a good supply, and that is because it is getting a lot of help from the ICA because of this large PCOM. So basically what we see in this case are two variant anatomies, that is, number one, a hypoplastic or absent A1 here on the right side, and number two is a fetal PCOM or fetal PCA, that is here. So these are the two anomalies that we are seeing. Okay, so now let's have a look at who are the people who gave a correct answer to this question. So this is our Facebook page, the comment section of the main post we are looking at right now. So what we see is Waji Ruisi. So yes, A1 is hypoplastic on the right side. That is true. No, there's no fenestration A2. And yes, right PCA, there is fetal origin of the right PCA. Left posterior communicating artery is not hypoplastic, so it's partially correct. No, this is not a patent trigeminal artery. Axel Kayembe, Partho Hazarika, hypoplasia of ACOM. No, it's not hypoplasia of ACOM, it's hypoplasia of A1. And yes, right side fetal origin is correct. Muhammad Kuse Al Sabag, aplastic right A1 and fetal origin of right PCA. Yes, that is true. So this definitely is the correct answer by him. And Utpala Chandradasa has said that it's right A1 segment aplasia, which is true. Right PCA is arising directly from right ICA, and right P1 segment is hypoplastic, right sided fetal origin of PCA. Absolutely correct. And Sunny Kumar, yes, it's fetal origin of right PCA, and A1 segment, yes, it can be hypoplastic on the right side. And if we look at the comment section of our Instagram post, then Arifatur Mania has said that its agenesis on the right side A1 segment and right fetal PCOM. Absolutely correct. And I might be wrong. She's saying that it's hypoplasia or agenesis of A1 and fetal origin of PCA. Yes, that is true. So these people have given the correct answer, as we have mentioned in this post right now. So thank you for your patience, and keep following Radiance for more such cases. Thank you.